Right. So we start our discussion of valvular heart disease with mitral stenosis. That's the valvular lesion you most commonly see in your wards. That's the valvular lesion that is very common in our country, especially because of acute rheumatic fever and its sequela of rheumatic heart disease, right? So besides rheumatic heart disease, are there any other causes for mitral stenosis? There is also Liebman-Sachs endocarditis of SLE. Rheumatoid arthritis can affect the mitral valve and cause stenosis. And atrial myxoma in the left atrium, because it blocks the path of blood flowing from the left atrium into the left ventricle, can also be a cause of functional mitral stenosis, although it's not valvular. And infective endocarditis with large vegetations can also cause significant MS. We'll discuss MS primarily as a rheumatic heart disease, right? So the chronic inflammation, see, why am I describing it as a chronic inflammation is because these patients often have recurrent episodes of acute rheumatic fever, right? And that therefore becomes the inflammatory process becomes chronic. Not only that, the valve thickening and fibrosis and in long standing MS calcific deposits cause the blood flow pattern to change. The valve gets progressively more and more deformed, and this sets up a vicious cycle, right? And therefore it propagates itself even if there are no further episodes of acute rheumatic fever. Of course, if there are, then the progression from the asymptomatic to the symptomatic stage is faster. Okay, eventually it becomes what is described as a fish mouth, which basically means a very small orifice, a very small opening at the apex of the valve, right? And the left atrium enlarges as compensation. Why? Because it has to accommodate initially a greater volume and it has to contract at a higher pressure for the left ventricle to fill effectively, right? So the left atrium enlarges, and as the atrium enlarges, an enlarged atrium is substrate for atrial fibrillation. Why is that important? Because this causes the MS to progress much faster. Besides that, another problem with AF and also a small problem, the calcification and fibrosis at the valve level itself, are that they will give rise to a thrombus, usually in the left atrial appendage, and that itself can give rise to systemic emboli. 20% of MS patients develop systemic embolization at some point in their lifetime, right? Let's look at how the hemodynamics work. The blue curve there is aortic pressure, and you will know that that would of course be unaffected in patients with pure isolated MS. Left ventricular pressure, so the left ventricle also is, that's the green curve, and the left ventricle also is unaffected or normally functioning in patients with pure isolated MS. It's the left atrium that bears the brunt of this valve stenosis, right? It has to enlarge, its pressure has to become higher for it to drive the pulmonary venous return into the left ventricle and therefore maintain cardiac output, right? So what happens is, see, this is your S1. So there's a loud S1, I'll come to that. This is S2. Often you have a single S2 in patients with mitral stenosis. I'll come to that as well. So this is the phonocardiogram, right? This is the ECG, the P wave, the QRS wave complex, and the T wave. This is the mid-diastolic murmur, which has a pre-systolic accentuation. This is the pre-systolic accentuation. This right here becomes louder just before systole, and that's because the atrial contraction causes the LA pressure to rise even further, right? So the dotted black line there is the left atrial pressure. So see the gradient between the left atrial pressure and the ventricular pressure, right? Now what happens is that the mitral valve closes here. How do we know it closes there? Is because at that point the ventricular pressure, the green curve, exceeds left atrial pressure, right? So the mitral valve closes, and just before it closes, the atrium contracts, which it normally does as well. Only thing is that the difference between left atrial and left ventricular pressure gradient is higher, right? So the mitral valve closes here. You hear a loud S1 in early MS, right? This is the phase of isovolumic contraction. Because the mitral valve is closed, the aortic valve hasn't yet opened. The aortic valve opens when the ventricular pressure is higher than aortic pressure. So that happens here. Of course, the left ventricle and the aorta are unaffected. So in pure isolated MS. So after that, the mitral valve opens right here, and it opens early. It opens early. The higher the left atrial pressure, and this sound can be heard as an opening snap. The higher the left atrial pressure, the earlier it's going to open, right? So, which is why they say that the A2 and the OS, the A2 OS gap interval is inversely proportional to the severity of mitral stenosis. It will open earlier. The A2S will be shorter if left atrial pressures are higher. Okay. So that's your mid-diastolic murmur with presystolic accentuation. That's the presystolic accentuation right there. This phase, and it's because of this strong atrial contraction, right? That's the reason for the presystolic accentuation of the mitral stenosis murmur, right? Okay. So how does it progress, right? The normal mitral valve has an area of 4 to 6 centimeters square, and significant MS is an area of less than 2 centimeters square. There are other categories. Severe MS is less than 1.5 and very severe MS is less than 1 centimeter square. What's the reason that these are defined in this manner? So in significant MS, what happens is that left atrial pressure, so a higher atrioventricular pressure gradient is needed, but this gradient is still able to maintain cardiac output, and the demand for an increase in cardiac output. When you stand up and walk, or you need to run or walk faster, anything that increases your the patient's cardiac output, right? That can be still met when the valve hasn't gone to a severe stenosis, right? What happens when there is severe stenosis is that at rest, here the left atrial pressure needed to maintain cardiac output is more than 25 millimeters of mercury. At this pressure, what happens at this pressure is pulmonary edema, right? So often these patients come with sudden hemoptysis, right? So their left atrial pressure is elevated. It's needed to be kept at a higher pressure than that which causes pulmonary edema to appear to maintain cardiac output. Okay. And what happens in very severe MS is that the cardiac output is low even at rest despite a high left atrial pressure. And what happens with exertion? It either fails to increase at all, or it actually can decrease, right? So that's the basis for classifying MS in that manner, right? The pulmonary circulation gets affected very early on in MS because all the blood volume that the left atrium cannot send to the left ventricle dams up or backs up into the pulmonary veins, right? And eventually these patients start to develop pulmonary hypertension. Early stages, they might have pulmonary edema and hemoptysis, and later on they develop pulmonary hypertension, right? So the left atrial pressure rises, that becomes a back pressure, and therefore pulmonary venous and pulmonary capillary pressures also rise. This is called a second stenosis. Important fact for you right there, right? what is second stenosis in MS? It's the pulmonary arteriolar constriction in response to raised left atrial pressure, right? So eventually what's going to happen with that is that the right ventricle will hypertrophy, it will enlarge, and over time, it's the right ventricle, even the enlarged hypertrophied right ventricle will not be able to compensate for the, overcome the pulmonary artery systolic pressures, and that is when the right heart can fail. So it will also give rise to secondary tricuspid regurgitation and pulmonary regurgitation, right? And therefore, when the right heart fails, then these patients will develop peripheral edema, raised JVP, and a tender, tense hepatomegaly, right? So the raised pulmonary artery pressures play a very, very important part in the natural history of mitral stenosis. Another thing that happens is that the lung volumes fall. So they will have, see, again, because of the, in initial stages, what's going to happen is that the pulmonary vasculature has not yet become thickened or fibrosed. So, and there is a leakage of fluid into the interstitial spaces of the lung. So what's going to happen is that total lung capacity, vital capacity, maximum voluntary ventilation, and DLCO will all get reduced. Small point here is that after a recent episode of hemoptysis, DLCO will be seen to be increased after a recent episode of hemoptysis, right? But eventually, as fibrosis occurs, as hypertension occurs, DLCO will reduce. So what are the symptoms and when do they occur? So these patients usually have a latent period of 5 to 20 years. Why such a long variable latency? Sometimes 5, sometimes 20. Depends upon the recurrent episodes of acute rheumatic fever, right? So in low socioeconomic strata, the latency will be shorter. When they don't get benzathine prophylaxis, then the latent period would be shorter. So initially symptoms appear only when the heart rate, blood flow, or cardiac output markedly change. Why heart rate? Heart rate, see, when there is tachycardia, the diastole shortens more than the systole, and therefore left ventricular filling gets significantly affected, right? Okay. So that happens when, that happens with severe exertion, that happens with excessive excitement, that happens with fever, anemia, thyrotoxicosis, that happens with pregnancy. Pregnancy doesn't tolerate mitral stenosis well. Okay. So what do they come with? They come initially with dyspnea and cough, right? And those are exertional in origin. As the disease progresses, as the valve becomes more and more stenotic, with lesser degrees of progression, symptoms start to appear. Okay, and orthopnea and PND, remember, so we said that hemoptysis occurs, right? Orthopnea and PND also occurs, but it is not due to left ventricular failure. The left ventricular functions normally in pure isolated MS. Please remember that. It's not receiving a lot of venous return. The aorta, its pressure is normal, right? So it has a reduced preload and a normal afterload. Why would it dysfunction at all? What dysfunctions is the left atrium? So orthopnea, PND, hemoptysis are due to left atrial failure in mitral stenosis, right? Eventually, AF sets in when the left atrium becomes very large, and that causes the disease to progress much faster. That also causes the significant complication of systemic embolization, right? We discussed hemoptysis. It's not that the only cause of hemoptysis in mitral stenosis is an increase in LA pressure. There are other causes as well. They are more prone to lower respiratory tract infections. They are more prone to pulmonary emboli also, right? So there's a multiple causes of hemoptysis in mitral stenosis. Broadly, those are the symptoms, right? Another interesting symptom is Ottner's syndrome or cardiovocal syndrome. It's because of entrapment of the left recurrent laryngeal nerve, that purple structure right there. So this structure, when it's trapped between the aorta and a dilated pulmonary artery, it's called Ortner's syndrome or cardiovocal hoarseness, and that can happen in any cause of severe pulmonary artery hypertension, okay, including mitral stenosis. What will you find on examination, right? So when they have a sinus rhythm and pulmonary hypertension, the A waves are prominent, correct? What does an A wave mean? An A wave means that the atrium and the ventricular rhythm are electrical rhythm are synchronous with each other. A wave will disappear in patients with AF, and they will have canon A waves in patients when they have, of course, that's not an issue here, but a complete heart block will give rise to canon A waves, right? On palpation, you will feel a left parasternal heave, which is evidence of right ventricular enlargement. The S1 comes loud and late, right? The reason for a late S1 is because the ventricular pressure takes time to overcome the elevated left atrial pressure. That's the reason the S1 comes late, right? And it's loud in early MS. In advanced late MS, the valve gets heavily calcified, and that's when you will not hear a loud S1, right? You might, the S1 might even disappear, okay? Any cause of increased cardiac output will cause a loud S1. So the causes that we just said will cause symptoms in MS, thyroidosis, anemia, pregnancy, they are associated with a loud S1, right? The P2 is loud because of pulmonary artery hypertension. There is a close split of S2 in mitral stenosis. When you do get two different sounds, you can also hear an opening snap in between. That's the sequence, A2, opening snap, P2. I described how the A2 OS interval, the opening snap is because of the opening of the stiff mitral valve, and it's best heard in expiration at the apex. The A2 OS gap is inversely proportional to severity of MS. The shorter it is, the more severe the stenosis is, because that implies that left atrial pressure is that much higher. And you hear a mid-diastolic murmur at the apex, and this can be accentuated by exercise. Anything that increases flow across the valve, right? So a mid-diastolic murmur best heard again at the apex in the left lateral position, breath held in expiration, right? Besides that, later on you will secondary findings, you will have the pansystolic murmur of tricuspid regurgitation. What's Carvalho's sign is that inspiration increases the intensity and duration of left-sided murmurs because of increased venous return with inspiration. You can also hear the Gram-Steele murmur of pulmonary regurgitation. That happens when the right ventricle enlarges and fails, and this therefore happens with severe pulmonary artery hypertension. It's a diastolic murmur heard at the left sternal border. All these auscultatory findings can disappear or become much less prominent when cardiac output is reduced, because then flow will reduce across the mitral valve. The ECG will show evidence of left atrial enlargement. That's called a P mitral, right? The bifid P wave in leads 2 and V1, that's the bifid P wave, that is a P mitral. You will later on get evidence of right axis deviation and right ventricular hypertrophy. The chest X-ray shows importantly a straightening of the left heart border. So the left heart border straightens out primarily because of enlargement of the left atrium appendage. Besides that, what they get is a double atrial shadow or a double right heart border. So that's the right heart border formed by the enlarged right atrium, and if you look carefully, you will see that this structure right here is the enlarged left atrium. So a double right heart border is seen in patients with mitral stenosis. You will also notice just above this enlarged left atrium is that the subcarinal angle is increased, right? And besides this, you will notice that the upper lobe veins are more prominent. There is pulmonary venous hypertension. The final finding that I would like you to note is curly B lines, right? So, these are the features in patients. The cardiomegaly, there the heart is enlarged in a right ventricular pattern. So, the apex shifts laterally, it does not go down. When the apex shifts laterally and inferiorly, that means it is a left ventricular enlargement. And when the apex just shifts outward laterally, that implies it is a right ventricular enlargement. Okay. So, that is the ECG and X-ray findings. And how do you treat them? So, penicillin prophylaxis to prevent recurrent episodes of acute rheumatic fever. So, either you can give them intramuscular benzathine penicillin. So, adult patients when their weight is more than 27 kg, 1.2 million units every 4 weeks. So, if you give it every 2 weeks or every 3 weeks, it is more effective, but very difficult to implement, right? You can also give oral penicillin, but that will have to be given daily. You can also give oral erythromycin, again daily. Oral medication is preferred when patients are on anticoagulation, because then you do not want to give them a deep intramuscular injection for fear of a hematoma, correct? So, how long do you give this prophylaxis? Either up to 21 years of age or 10 years after the last episode of acute rheumatic fever. Please remember these words very carefully, whichever is longer. Okay, they will quiz you on this. They have quizzed you on this multiple times, so please remember this. So, when MS is associated with any of AF, history of thromboembolism or a left atrial thrombus, you will give them vitamin K antagonist, not a direct oral anticoagulant, no apixaban, no rivaroxaban. Okay. So, warfarin with a target INR of 2 to 3, correct? The definitive therapy for all symptomatic patients with MS is percutaneous mitral balloon commissurotomy, right? You can't do that unless there is significant MR. That is when you need to do a mitral valve replacement, okay? Or when a prior percutaneous procedure has failed, right? And patient is still significantly symptomatic when they have NYHA 3 or 4 dyspnea, right? And what would you do for the pregnant patient with MS? When will you need to treat them? When they have pulmonary congestion. So, then you need to do a percutaneous procedure for the pregnant patient with MS. On to mitral regurgitation. Now, MR is a very different entity compared to MS. Why? Is because MR can occur acutely in a matter of minutes, right? So, we need to distinguish acute from chronic MR, right? Acute MR manifests as pulmonary edema, cardiogenic pulmonary edema. Chronic MR manifests initially with exertional fatigue, forward failure. I'll describe how, right? So, very importantly, is the mitral regurgitation acute or chronic? What are the settings in which acute MR occurs? So, acute MR can occur with ischemia, like an acute myocardial infarction in which one of the papillary muscle ruptures. It becomes so necrotic that it ruptures, right? It can occur as a flash pulmonary edema with angina, right? In coronary artery disease, even in an angina episode, it can cause. So if the papillary muscle becomes extremely ischemic during an episode of angina, it can cause acute MR and flash pulmonary edema, right? Acute MR can also occur with infective endocarditis. The vegetations can destroy the valve leaflets, right, or perforate the leaflets. It can also occur in blunt trauma to the chest. Okay, it's a medical and surgical emergency if there ever was one, right? The patient can die within minutes. Chronic MR, the causes are, we all know, rheumatic origin, right? So acute rheumatic fever going on to rheumatic heart disease with mitral regurgitation. Besides that, there is myxomatous degeneration, right? And myxomatous degeneration can occur as part of an entity called Barlow's disease. This can sometimes cause, while it is a chronic form of MR, it can sometimes, if the chorda tendina ruptures, it can give rise to acute on chronic MR, right? So we'll keep distinguishing between acute and chronic varieties of mitral regurgitation as I go along, right? So mitral regurgitation can be because of disease of leaflets, the annulus itself. If the annulus stretches very widely, that can cause the leaflets will not coapt if the annulus is very large. The chordae tendineae, right? If the chordae tendineae rupture, for instance, then that ruptured chorda will not be able to hold the valve in place when the ventricle contracts, and therefore it will allow regurgitated jet into the left atrium, correct? It can be because of papillary muscles, because that's what the chordae are attached to, and it can be because of the adjacent myocardium. Now let's look at the disease examples where each of those components can get involved, right? So infective endocarditis can either perforate the leaflets, destroy the leaflets completely, right? Annulus, disease of the annulus, for example, cardiomyopathy. And cardiomyopathy is also an example of disease affecting the adjacent myocardium and causing MR. Another example of disease affecting the adjacent myocardium and causing mitral regurgitation is hypertrophic obstructive cardiomyopathy with systolic anterior motion of the anterior mitral leaflet, right? Okay. Then chordae tendineae, we said myxomatous generation can cause disease of chordae tendineae. Papillary muscles that can get affected with either of myocardial infarction or even an episode of angina. And we discussed cardiomyopathy like hypertrophic cardiomyopathy or a dilated cardiac myopathy as example of adjacent myocardium leading to mitral regurgitation. So again, when you look at those causes, there's another type of classification. And that classification is also very important. It's primary versus secondary mitral regurgitation. The disease of the leaflets and chordae is considered primary MR, whereas or degenerative MR, whereas disease of the annulus, of the muscles and the adjacent myocardium is considered secondary or functional MR. Please don't be confused with the word functional, with the terminology functional. It does not mean that it is not hemodynamically significant or that it is secondary to another valvular lesion or excessive flow. No, can be overwhelmingly significant and worsen the left heart function in these patients. Okay, so distinction into acute versus chronic MR and primary versus secondary MR, because that's how you approach treatment of these patients. Okay, more on this as we keep discussing. So mitral regurgitation, when it's because of rheumatic heart disease, the chronic inflammation, as we discussed with mitral stenosis, causes valve rigidity, deformity and retraction of the cusps. Okay, again the flow pattern changes. There is a progressive dilatation of the annulus, and this especially affects the posterior mitral leaflet. See what's going to happen in, now this is a chronic MR, right? So it's going to, rheumatic heart disease, chronic inflammation, multiple episodes of acute rheumatic fever, and the valve gets progressively deformed and the cusps retract away from each other. And see what's going to happen is that the left atrium, when it empties into the left ventricle, a lot of the jet comes back gradually. So it's a volume overload for the left atrium. Okay, gradually left atrial compliance will increase. How will the left atrial increase its compliance? By increasing in size, right? So the left atrium gradually keeps on enlarging. As it enlarges, it especially pulls backward the posterior mitral leaflet. What will happen with, if that is pulled backwards? More MR. More MR will mean more left atrial enlargement. So therefore MR begets MR, right? That's the aphorism, clinical aphorism. So the left atrium enlarges this and it pulls on the posterior mitral leaflet, and therefore that vicious cycle gets established. Now, what's happening to the LV is that so when chronic MR starts, things are very nice for the left ventricle, right? It empties into the aorta, but the aortic pressures are very high, right? 120 systolic pressure, whereas it can empty very easily, decompress very easily into the left atrium. So for a span of time, a few years, the left ventricle is happy and does well. Gradually what starts to happen is that as the regurgitation increases, now the left atrium is also receiving pulmonary venous return, right? So this keeps adding up. The regurgitant jet and the pulmonary venous return keep adding up and cause a left ventricular volume overload. Over time, so initially it will hypertrophy, it will dilate and compensate, eventually it will fail. Okay, so the LV enlargement also further stretches the mitral annulus, correct? And therefore we go back to the more MR, and that allows more left ventricular volume overload, more left ventricular enlargement, and more annular stretching. So MR again begets MR. The positive vicious cycle of chronic severe MR continues even if there are no further episodes of acute traumatic fever. So if they ask you in the exam, what's the cause of a giant left atrium, and you need to choose between MS and MR, which do you think will cause more enlargement of the left atrium? Is it a condition in which the left atrium is contracting and trying to push blood content into the pulmonary venous return into the left ventricle, or is it the condition in which the left atrium is enlarging to accommodate the regurgitant jet from the LV? So this is primarily a pressure overload of the left atrium. This is a volume overload. Because this is a volume overload, the left atrium continues to become larger progressively. Giant left atriums are seen with mitral regurgitation. Okay, no matter what anyone else tells you, please remember giant left atrium, mitral regurgitation. Okay, that's the pressure curves. Okay, so this here is the atrial pressure. So in mitral stenosis, we saw that the atrial pressure was significantly higher than the left ventricular pressure, correct? That's the presystolic accentuation of the mama, the atrial contraction which causes presystolic accentuation. On the other hand, here you will see that the left atrial pressures are not very high except late in ventricular systole. Now, why does atrial pressure rise so much in ventricular systole, late in ventricular systole? Is because it receives the regurgitant jet of MR, and the pulmonary venous return also fills it up. So, that is why the atrial pressures tend to increase in late ventricular systole. Okay. Now, besides that, what will happen is that when will you hear the murmur? The murmur will be heard as soon as the gradient between the ventricle. So, the murmur is because of what? It's a regurgitant jet into the left atrium. So, blood is going back during ventricular contraction, blood goes back into the left atrium, right? And immediately upon ventricular contraction, the murmur starts off. So, it starts off with S1, right? So, which is why the S1 is soft, the valves don't close together. So, because they don't close together, what causes an S1 is when the valves close and go up into the slightly up into the left atrium with ventricular contraction. The tensing of the chordae and the blood column is what sets up those sound vibrations that cause S1, correct? Now, here the valves are not coapting, the leaflets are not coapting. So, the S1 is either soft or absent, and it is also buried in the holosystolic murmur of MR. Now, will mitral regurgitation always give rise to a holosystolic murmur? Is it possible that it can give rise to an ejection systolic murmur, which goes away or fades away during mid systole to late systole? So, yes, in acute MR, how is acute MR different? In chronic MR, what happens is that the left atrium gradually enlarges, accommodates the increasing regurgitation from the left ventricle. In acute MR, the left atrium does not have that time frame to adapt to that regurgitant volume. So, in acute MR, the left atrial pressure rises very significantly. And because this left atrial pressure rises very significantly, what's going to happen is that this peak will come earlier. If this peak comes earlier, the murmur tends to fade off during late systole. Correct? Understood? Okay, let's keep moving. What are other important causes of MR? This is very important for your exam. So, DCMP, a dilated cardiomyopathy, because the annulus gets stretched, and when it does it become important? When the end diastolic diameter of the left ventricle, after it's received the full venous return is supposed to receive, when that diameter is more than or equal to 6 centimeter, it will start to cause significant mitral regurgitation. Okay. I told you about hypertrophic obstructive cardiomyopathy when it is associated with systolic anterior motion of the anterior mitral leaflet. This is a dynamic regurgitation. So, it can vary from beat to beat depending upon how much the AML moves forward. Okay. And then ostium primum atrial septal defects are associated with a cleft in the anterior mitral leaflet. This is all important questions. Endocardial cushion defects are associated also with mitral regurgitation. Okay. Other important facts about mitral regurgitation: the Carpentier classification is used for defining leaflet mobility in MR. Just the name is enough. There are classes, but you don't need them. Then besides that, what is chronic severe MR? How do you quantify chronic severe MR? So, there are 3 criteria, and all 3 of those must be satisfied. So, that those 3 criteria are the regurgitant volume, the regurgitant fraction, and the orifice, the regurgitant orifice, right? So, when the regurgitant volume is 60 ml or more per beat, when the regurgitant fraction is more than 50%, and the regurgitant orifice is effective regurgitant orifice area is 0.4 centimeter square or more. So, when all those 3 together are satisfied, you can label your patient as having chronic severe MR. Okay, what are the findings that you will see? So the apex will be shifted laterally. Why? Because it's a left ventricular volume overload. Correct? So it's going to be shifted laterally, down and out. The apex of MR is down and out. Volume overload of the left ventricle, it goes laterally and inferiorly. So you can get it maybe in the 6th or the 7th intercostal space, often as far as the anterior axillary line, depending upon the severity, the co-existing valve lesions, right? The S1 we discussed why it's soft or absent. The S2 has a wide split with preserved respiratory variation. Why does it have a wide split? Now here pulmonary hypertension is not developing. What's happening is that the A2 comes early. Why is that? The left ventricle empties into the aorta and as well into the left atrium. It empties into the, decompresses more into the left atrium because that's the path of lesser resistance. So A2 comes, the aortic valve closes earlier. That's why you have a wide split, but with, so this is called a physiologic split, where the respiratory variation, that is in inspiration, you hear that the split widens even further. Okay, and S3 can be heard from the left ventricle even with no, so when we talk of left ventricular S3, we are talking of left ventricular failure, right? But in MR, when the regurgitant volume is very high, what happens is that when that volume comes back into the left ventricle, that rapid ventricular filling can cause an S3 to be heard, right? Okay. I told you that in chronic mitral regurgitation, what you will hear is a pansystolic murmur and ejection systolic murmur, which is decrescendo. Crescendo means the volume is increasing, decrescendo means the volume decreases in mid to late systole. So that's heard in acute MR, right? And the chronic MR murmur intensifies with hand grip, like it causes isometric exercise. That's, you will ask your patients not to do isometric exercise. Their regurgitation increases. Why is that? Is because what happens with isometric exercise is that the left ventricular afterload increases with isometric exercise. So the left ventricle cannot empty easily into the aorta now. It will empty more towards the left atrium. Correct? That's one. And it is decreased in the strain phase of Valsalva. Why would it decrease in the strain phase of Valsalva? Is because in this phase, when there is highly positive intrathoracic pressure, is when the venous return from the lung would reduce, right? Okay. Important facts, they would ask you this. Will it increase or decrease? And these are the things that you tend to forget. And this is the reason we are doing this marathon to the NEET PG 2024. ECG, again, left atrial enlargement. So you get a P mitral as we discussed with mitral stenosis. The natural history, pulmonary hypertension will develop, but very late in the course. Okay. Early on, it's just a volume overload. The chest X-ray now shows cardiomegaly with a left ventricle type of down and out. The apex is down and out. So there is cardiomegaly. There is a double right heart border. Can you make that out? So that's the left atrium and that's the right atrium. Sometimes the left atrium is so large in mitral regurgitation that it forms the right heart border. Okay, so that's what you get in patients with isolated or pure mitral regurgitation. And again, because of the large left atrium, the subcarinal angle is wider than normal. And while this is chronic severe MR, this is what you get in acute severe MR. So, upper lobe redistribution of opacities and pulmonary edema. Right? Moving on. How you treat these patients with mitral regurgitation? you would divide them. We said that the classification is important because that's how you approach treatment. So, is it an acute MR or is it a chronic MR? Is it a primary MR or is it a secondary MR? And I'll just show you how. So, for acute severe MR, whether it's primary, that is because of disease of the leaflets or chordae, or secondary annulus, papillary muscle or myocardium, acute severe MR is a big emergency, right? So, the causes we discussed are ischemic, infective endocarditis and blunt chest trauma. Now, you will urgently stabilize the patient, which means correct their pulmonary edema. You might need to give them an intra-aortic balloon pump if their LV is very poorly compromised. You might need to give nitroprusside to reduce afterload and further help the function of the left ventricle. You might even need to ventilate your patient, right? And while you do an urgent stabilization, you prepare for an urgent surgery. Okay, that's how you treat acute severe MR. Now, very importantly and interestingly, you will notice that perioperative mortality and adverse cardiovascular events are higher when you replace the valve. Why is that? Valve repair seems to be better. There are fewer thromboembolic complications. This is why. Is because you preserve the subvalvular apparatus. In valve repair versus valve replacement, the left ventricle functions better. So, when a repair can be undertaken, valve repair is definitely superior to valve replacement. Okay. These days, there's transcatheter end-to-end repair with a device, clipping device called the mitra clip, right? And this is fast becoming the procedure of choice for patients with need a surgical intervention for mitral regurgitation. Okay, right. Chronic severe MR when it's primary, which means disease of the leaflets or chordae. So, when it's rheumatic in origin, you will use prophylaxis against group A streptococci, gaspharyngitis. You will use warfarin. You can also use direct oral anticoagulant. Now, with MS, I said that warfarin is definitely superior to the drugs like apixaban and rivaroxaban. Not so for pure MR. For pure MR, you can use either. Both are as good as the other. But when there is associated moderate to severe MS, or the patient has a prosthetic mitral valve which is mechanical, then again you go back to warfarin. Very, very important. They will likely quiz you. So, if I were the examiner, I would quiz you on this. When can you use directly acting oral anticoagulants and when can you not use them for thromboembolism prophylaxis in MR? Of course, you give that according to the Church-Vasquez score. So, you use it when there is a left atrial thrombus, when there is a history of thromboembolism, or there is atrial fibrillation, because the left atrium is so enlarged, it can give rise to all of those, right? So, initially it's a forward failure. What are the symptoms? It's a forward failure. The left ventricle easily empties into the left atrium. So, forward output, the cardiac output is not as well. So, and interestingly, what will you get on echocardiography? The left ventricular ejection fraction, how much of the left ventricular volume empties during systole, will be very high, right? But the problem is that a lot of it is not going into the aorta and going into the left atrium. So, the ejection fraction overestimates left ventricular function in MR. So, that means that when the EF is even mildly reduced, and the EF is below 60% in patients with chronic severe MR, they have significant left ventricular dysfunction, right? Okay, important fact to remember once again. So, symptoms will be fatigue. Initially, they will come with fatigue. Eventually, when EF develops, then of course palpitations and dyspnea, cough sometimes. when pulmonary hypertension also starts to develop late in the course, right? And features of LV dysfunction. So you might have orthopnea, you might have paroxysmal nocturnal dyspnea, right? And when the important thing here is that when these patients either have symptoms or have left ventricular dysfunction, this is indication for valve repair. Maybe they will give you this, maybe they won't. This is transcatheter end-to-end repair with a clipping device. Okay, and this is superior to valve replacement. I told you why, because this preserves the subvalvular apparatus. Okay, and the left ventricle functions better. Fine. Chronic severe secondary MR is more complicated. So here you have cardiomyopathies, dilated cardiomyopathy, ischemic cardiomyopathy. How do you treat these patients, right? So in cardiomyopathy, that's one of the causes of chronic severe secondary MR. At first, you treat the heart failure, right? So you will give them vasodilators like AC inhibitors, angiotensin receptor blockers. You'll give them beta blockers. You'll give them the angiotensin receptor neprilysin inhibitor. You give them diuretics, both loop diuretics and potassium sparing diuretics, mineralocorticoid receptor antagonists like spironolactone. You'll give them SGLT2 inhibitors, right? And eventually you might need to use biventricular cardiac resynchronization device, right? So biventricular pacing may be needed to optimize treatment of refractory heart failure in patients with chronic severe secondary MR. That's a CRT device. Biventricular pacing is the preferred modality of treatment, right? But when this fails to control symptoms or the left ventricle continues to dysfunction, that is when again you will resort to valve repair. Right. So having covered mitral stenosis and mitral regurgitation in some detail, we are in a position now to progress faster because we've discussed how the pressure and volume relationships of the different cardiac chambers work, right? Especially here, we are discussing left-sided valvular lesions. So our next lesion that we're discussing is aortic stenosis, right? And what all can cause it? Of course, we know that rheumatic heart disease is one very common culprit. Besides that, uh, congenital abnormalities, so a unicuspid, a bicuspid aortic valve, or a commissural fusion can all cause aortic stenosis, right? Degenerative calcific disease that occurs with aging is another important and common cause of aortic stenosis. We discussed rheumatic fever, and mediastinal radiation can also cause the aortic valve to degenerate, calcify, thicken, and become stenosed. Right? Okay. So the stenosis always begins as a sclerosis. What is a sclerosis? Where the valve is diseased, but there is no obstruction to left ventricular outflow. That is sclerosis. All aortic stenosis begins as aortic sclerosis. Aortic sclerosis will be seen in almost every individual if an autopsy is done after the age of 70, 75, right? But aortic stenosis is not synonymous with aortic sclerosis. You label it as aortic stenosis when there is obstruction to left ventricular outflow, right? So it's an active process. While we said that a degenerative process, a degenerative calcification can cause aortic stenosis. It's not like, the graying of hair and the osteoarthritis that occurs in the knees and the deterioration of memory, although there is evidence that even those are active processes. But here too, inflammation plays a very, very important role, as does endothelial dysfunction and accumulation of atherogenic lipids. So the myofibroblasts actually differentiate into osteoblasts, and that causes the laying down of calcium crystals, calcium hydroxyapatite crystals. The same conditions that are risk factors for coronary artery disease are also risk factors for aortic valve sclerosis and stenosis, right? Now, a quick mention of bicuspid aortic valve. It's the commonest congenital abnormality of the aortic valve. It's the most common congenital lesion in the adult heart. Okay, and it's inherited in an autosomal dominant pattern, but there is incomplete penetrance, which means not everyone who has the mutated gene will manifest the disease, and the severity of the disease will also be variable among different individuals. There is some talk of a possible X-linked inheritance also, because aortic stenosis is more common in Turner syndrome, right? And this valve is very highly susceptible to infective endocarditis. Besides aortic stenosis, they can also have progressive AR. They can also have an aortopathy, which can manifest as simply as a dilatation, as an aneurysm, and as a dissecting aneurysm, right? So, rheumatic disease, the same vicious cycle of inflammation and then valve distortion. The structures get distorted, the commissures get a fused, distorted valve, deformed valve becomes more susceptible to trauma, and which eventually leads to fibrosis and narrowing. And then this fibrosis and narrowing allows greater susceptibility to trauma, and then trauma itself causes more inflammation, and the vicious cycle perpetuates itself. Now, what's the pathophysiology of severe aortic stenosis? Now, I'm not talking of mild or moderate aortic stenosis, because those, when aortic stenosis is mild or moderate, it is asymptomatic. When aortic stenosis is causing symptoms, you can understand that this must be severe AS, and I'll come to what that is. Okay. How does the heart compensate for severe aortic stenosis? If there is obstruction flow to outflow from the left ventricle must undergo hypertrophy. So a progressive concentric left ventricular hypertrophy occurs, and it's necessary because the orifice has become less than 1/3 of its original. Normally, it's about 3 to 4 centimeters square, and severe AS is an orifice area of less than 1 centimeter square, or a systolic pressure gradient of more than 40 between the aorta and the left ventricle. Right? Now, what are the consequences of this? What happens is that this progressive concentric LVH would imply greater myocardial oxygen demand, right? The hypertrophy would also mean more stiffness, less compliance, right? When you put on a lot of muscle, you become a little arrogant. So that's what happens with this fellow here. The left ventricle becomes less compliant, becomes more stiff. Its myocardial oxygen demand increases. Now, what will happen to the cardiac muscle, which is hypertrophied? There is obstruction to left ventricular outflow, and in which the compliance is poor. Now, poor compliance, very, very interesting thing is that because the compliance is poor, the left ventricle can only receive a certain small amount of, so its end diastolic volume will be smaller, and a large part of it can be pumped out even across a stenotic valve, right? So let's say that if normally 100 ml is going to be received, is the normal, just for pure understanding, right? And these values are not accurate. So if the normal left ventricle has an end diastolic volume of 100 ml, a poorly compliant, stiff, hypertrophied left ventricle, this drops to 70 ml. Now, the left ventricle, which is hypertrophied, can pump out about, let's say, 60% of this, which will work out to 42 ml, right? If the left ventricle were to pump out 42 ml of this, ejection fraction would be 42%. Whereas here, this ejection fraction is 60%. And we are talking of a valve which is stenotic. So it's the absolute value that is also important here. The problem is the left ventricle cannot increase cardiac output when that is required, right? So exercise will require vasodilatation in the exercising muscles. vasoconstriction in the non-exercising muscles, that can't happen, right? And so LVH implies myocardial oxygen demand increases. It implies that the left ventricle is stiffer now. Severe AS implies that the cardiac output becomes fixed. It cannot be increased when an increase in cardiac output is required, as simple as walking fast from one end of a room to the other. So what are the consequences of this? If the oxygen supply is not met with, then your patient will have angina, and the subendocardiac muscle is the most vulnerable. Subendocardiac cardiac muscle is the most vulnerable, right? Because the arteries, the epicardial arteries, penetrate through the substance of the myocardium, and because the left ventricle is hypertrophied, when it contracts during systole, the arteries going through the substance of the myocardium also get compressed. Okay. Besides this, another problem that will happen is that these patients, if their cardiac output cannot increase when it should, they will start to manifest. When they exert themselves, they can have a syncope. Fine. And finally, after many years of the left ventricle compensating with hypertrophy, eventually the left ventricle will start to fail, because the hypoxic, hypertrophied, poorly compliant left ventricle is a substrate for irreversible myocardial fibrosis. Okay, so in that sequence, angina occurs first, followed by syncope, followed by LV failure. They have about 3 years to live when angina occurs, provided you don't take definitive therapy. They have about 2 years to live when sin appears, and when LV failure appears, they only have about 1 to 1.5 years of expected lifespan, right? And while these symptoms typically would occur at 6 to 8 decades, so around 70 years of age, for most patients with chronic aortic stenosis, either rheumatic or degenerative calcific. But for bicuspid aortic valves, the symptoms occur almost 2 decades earlier. They can occur with bicuspid aortic valve, symptoms can occur even earlier than that. So even a 10-year-old with a bicuspid aortic valve, if there is both AS, AR, and an aortopathy, this patient might require a surgery as early as 10 years of age. So progression is faster for bicuspid aortic valve disease, leading to aortic stenosis, aortic regurgitation, and or aortopathy. Okay, I hope that you're familiar with this graph now, and the dotted curve there is the left atrial pressure curve going high up. That's the left ventricular pressure, and this, of course, is the aortic pressure, right? So this is the gradient between the left ventricle and the aorta. When flow occurs, that's when you hear the systolic murmur of aortic stenosis, right? Moving on, coexistent valve disease, when AS is having coexistent mitral stenosis. Let's look at aortic stenosis primarily. The problem with aortic stenosis is that it's a pressure overload on the left ventricle, right? Now, what happens with MS is that a very little volume is coming into the left ventricle if there is mitral stenosis. So, mitral stenosis offloads the left ventricle. So, it masks the findings and severity of aortic stenosis. If AS and AR coexist, as is often the case, then AS is only a pressure overload. Aortic regurgitation, and we discuss that next, is both a volume and a pressure overload. I'll describe that there. So the LV will fail much faster. LV failure occurs faster, right? And based on the appearance and progression of symptoms. It's also possible to decide whether stenosis is more prominent lesion or regurgitation is more prominent lesion. I'll describe that when I describe aortic regurgitation. When there is both aortic stenosis and mitral regurgitation, what happens to the LV? So AS, again, pressure overload, mitral regurgitation, volume overload. So again, the left ventricle decompensates faster if there is both aortic stenosis and mitral regurgitation. Okay, I hope those things are clear. What would you find when you examine these patients, right? So you have a slow rising carotid pulse, pulsus parvus et tardus, right? So it's tardy, which is slow, it's parvus, which is weak. The carotids can exhibit a thrill or an anacotic shudder. There can be a prominent A wave in the JVP. Why? What's wrong with the right ventricle? If the left ventricle muscle is very hypertrophied, then the hypertrophied IV septum is bulging into the right ventricular cavity and compromising it. That's the reason for the prominent A wave in the JVP. The apical impulse is located normally until very late in the course. When there is a profound left ventricular hypertrophy and eventually the left heart fails, it shifts a little laterally. Okay, there can be a double apical impulse with a palpable S4 as well. You can palpate a systolic thrill in the first aortic area, which is the right second intercostal space, right? And which coincides with the ejection systolic murmur of aortic stenosis. There can be an ejection click or an ejection sound while the valve is still pliable. The S2 is either narrowly split or paradoxically split. Why? Because the left ventricle takes a long time to empty. So the A2 is delayed, right? That's the reason the S2 can be, the second heart sound can be narrowly split or paradoxically split. You can hear an S4 at the apex, which is due to a stiff and hypertrophied left ventricle. When the LV fails, you can even hear an S3, right? And the hallmark ejection systolic murmur is also heard in the right second intercostal space. The A2 area is the left third intercostal space. In fact, there's a phenomenon with the AS murmur, which is called the Calaverden phenomenon. As you go down, if that's the manubrium sternum, and that's the sternal body with the xiphoid process, and that's the second intercostal space, and if this is the A1 area, right, and so this is the A2 area or the herbs area. As you come down in this direction, you will hear that this systolic murmur will initially disappear and then reappear at the second aortic area. This phenomenon is called Calaverden phenomenon. It can cause you to confuse aortic stenosis with mitral regurgitation. Okay, so both the ejection sound and the A2 will disappear when the valve becomes heavily calcified and rigid, right? How do you treat severe aortic stenosis? So you tell all patients, irrespective of whether they have symptoms or not, to avoid strenuous exertion because they can't increase cardiac output. They have fixed cardiac output, right? If they are symptomatic, they need surgery. You could either do a surgical replacement of the valve or you could do a transcatheter aortic valve implantation, right? TAVI is the procedure of choice now, and I come to that in a second. Okay. So when they are asymptomatic, when do you need to go in for a valve replacement? If the ejection fraction is low. So if the LV starts to fail, even in the asymptomatic patient, that's when you need to put in a new valve, right? And if they are undergoing another cardiac surgery. Asymptomatic patient undergoing CABG also has severe AS, which is asymptomatic. You will do a valve replacement. Okay, right, or a aortic aneurysm repair. Fine. When the AS is due to bicuspid aortic valve, now this is a bigger problem, correct? So you will do an aortic valve replacement if the root of the aorta or the ascending aorta has a diameter of more than 5.5 centimeter. Remember this figure, right? If the patient has a family history of an aortic catastrophe, so if they've had an aneurysmal rupture or aortic dissection, then you do this when the diameter is more than 4.5 centimeter. So you do it, the threshold reduces if there has been a family history of aneurysmal rupture or dissection. So that's aortic stenosis. Moving on, yes, the valve can regurgitate as well. And you're starting to think, why do we need so many valves in the heart? So what are the causes again? So again, a bicuspid aortic valve, we said when we discussed aortic stenosis just now, is that it can give rise to AS, it can give rise to AR, it can also give rise to an aortopathy. Okay, bicuspid aortic valve becomes symptomatic much earlier. When you start getting patients earlier on with aortic stenosis, aortic regurgitation, you're probably dealing with a bicuspid aortic valve, right? It could be rheumatic, and when it's rheumatic, it's never isolated AR. It will always be associated with either aortic stenosis or mitral valve disease. Okay, infective endocarditis and retrograde dissection of the aorta, very, very important causes because they give rise to acute aortic regurgitation, which manifests as cardiogenic shock, right? Aortic root disease because of medial degeneration, as in Marfan syndrome, as in osteogenesis imperfecta, are also causes of aortic regurgitation. Besides this, syphilis and ankylosing spondylitis can cause disease of both the valve leaflets as well as the ascending aorta or the aortic annulus. Fine. What's the pathophysiology here, right? Whatever the left ventricle pushes out into the aorta comes back during late systole and during early diastole, right? So the end diastolic volume of the left ventricle is going to increase, right? So there will be an elevated left ventricular end diastolic volume. So that's the definition of an increased preload. It is yet to contract, right? So the LV is facing a volume to begin with in chronic AR. We're discussing chronic AR. In acute AR, the left ventricle is incapable to handle the regurgitant flow, so it just fails, right? The left ventricle therefore dilates. So here the dilatation occurs much earlier. When we discussed aortic stenosis, we said that it compensates initially with LVS. The dilatation comes much later. Here it dilates early and undergoes eccentric hypertrophy. Why is there eccentric hypertrophy? Is that the end diastolic pressure also increases with aortic regurgitation because of the hypertension. The stroke volume increases. See, the left ventricle pushes out blood into the aorta, and that happens in systole. And in late systole and diastole, a lot of this comes back and collects in the left ventricle. So one thing that's a problem for the left ventricle is an increased end diastolic volume. It's receiving regurgitant blood from the aorta. It's also receiving pulmonary venous return from the left atrium. Now, because of this increased stroke volume, it pushes it out during the next systole, and this increased stroke volume starts to cause hypertension. And this hypertension becomes an afterload on the left ventricle, right? So you will see that these patients will be found to have systolic hypertension and low diastolic blood pressures. So wide pulse pressure is seen. And because of the increased systolic blood pressure, which is due to the increased systolic volume. And afterload is also posed on the left ventricle in time, and therefore there is also increase in left ventricular end diastolic pressure. Okay, symptoms occur after the left ventricle function reduces. What did we discuss for aortic stenosis? The first thing that symptoms appear are angina, then syncope, and the dyspnea of LVF occurs last of all, right? Here, the left ventricular function falls, and that's when symptoms appear. So, until the left ventricle is functioning normally, at most the patient will experience forceful palpitations. Okay, myocardial ischemia will occur here as well, but again, this will also be a late manifestation. And I just told you that in an aortic stenosis, ischemia is the first manifestation to occur and manifest as angina, and heart failure, left ventricular failure, is the last to occur in aortic stenosis. So this is how you distinguish when there is both aortic stenosis and aortic regurgitation. How do you say whether it's predominant AS or predominant AR? If left ventricle failure occurs early on in the course, that means you're dealing with aortic regurgitation. If the patient does not have LV failure, there is no orthopnea, no paroxysmal nocturnal dyspnea, then, and instead the patient is having exertional angina, then you're dealing with predominant aortic stenosis. Again, the same graph that we are now becoming more familiar with. I will ask you to note the aortic pressure especially. See that the diastolic pressure falls drastically, right? And comes down to a value of less than 15. Indeed, the Korotkov sounds can be heard even without inflating the sphygmomanometer, the blood pressure apparatus cuff, right? So the pressure is reported as being 170 by 40 by 0. When they muffle is when you say that this is the diastolic pressure. And this is the reason that you're able to see so many clinical signs in aortic regurgitation. Thank God, some clinical signs are easily visible, right? Otherwise, so many signs, a lot of others, murmurs, so many others would say it's systolic, diastolic. You can hear a click, and you alone are thinking, my God, is there something wrong with my high frequency? Do I have some hearing loss? No, you don't. And so what happens is a very high stroke volume, right? And then a lot of that goes back into the left ventricle, correct? So the large arteries, because of the high stroke volume of the left ventricle, they become suddenly, they undergo prominent distension. And then right after, stroke volume that's come out into the aorta goes back, regurgitates into the LV. So then there is a sudden abrupt collapse of these vessels. That's the reason for all the signs associated with a wide pulse pressure, right? So a diastolic murmur, an early diastolic murmur is typical, is the typical finding in aortic regurgitation. You hear it better in the second aortic or the left third intercostal space. In early stages, you have to ask the patient to lean forward, breath held in, expiration. Okay, so that's why these graph findings are in this manner. Palpitations can be either rate related. So your patient comes and says, my heart is, beating like it's nobody's business. Doctor, 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 doctor. That those are rate related palpitations, as occurs in a supraventricular tachycardia. Or they can be forceful palpitations, as occurs in patients with AR, where the LV has both volume and pressure overload. So the left ventricle is increasing in size. It's also hypertrophy. You get the most massive left ventricles in patients with aortic regurgitation. The left ventricle alone can be more than a kg on autopsy. Okay, so they can experience forceful palpitation and they become worse with exercise. So exertional dyspnea is the first manifestation to occur after palpitations. Orthopnea and PND when the LV function falls, and we discussed that this falls early on in patients with aortic regurgitation. That's when symptoms appear. Angina is a late manifestation of aortic regurgitation. Of course, AS and AR can also give rise to, eventually the back pressure will cause the left atrium also to enlarge and unable to accommodate pulmonary venous return. That will lead to pulmonary hypertension. That is very late. Those are very late phenomena with the disease of aortic valve alone, right? What do you expect on examination, right? So as we were saying, the high stroke volume from the left ventricle causes a pronounced distension of the large arteries, and the regurgitation back into the LV causes a quick collapse of the same vessels. And therefore, you get all those signs, the Hill sign, the Duroze's murmur, the Trobb's pistol shot over the femoral artery, the Quincke's pulse, the Corrigan Waterhammer pulse, are all because of this wide pulse pressure. And the wide pulse pressure because of the high stroke volume from the left ventricle causing systolic hypertension, and the regurgitant jet into the LV causing fall in diastolic pressure. Right? So all these are manifestations of the wide pulse pressure. Okay. It's like they have a bobbing head, they have a pulsating uvula, right? And it's like trying to check out, is there something that's not vibrating or bobbing in this guy? So, apical impulse now is heaving, right? And it's down and out. It's down and out. So it's a sustained lift. Otherwise, the apical impulse, just the apex comes, touches your fingertip and goes away. But here there is a sustained lift to your finger when you palpate the apical impulse. It's down and out. That means it's not in the fifth intercostal space, it's maybe in the sixth or seventh intercostal space. It's lateral to the midclavicular line. It might have gone all the way to the anterior axillary line, right? You can get a double systolic wave you can feel a double systolic wave in the carotids. That's called a Bispherians pulse. That can occur with pure AR, that can occur with AS and AR combined uh, valve lesions as well. The A2 isn't heard, right? Because the aortic valve is not closing. That's aortic regurgitation for you, isn't it? And the murmur, the classic murmur, is decrescendo. Why is it decrescendo? Why is it reducing in intensity during diastole? Is that over time the pressure gradient, so the left ventricle is at a higher pressure than the aorta. But during diastole, when the left ventricle is relaxing, there will come a time when the pressures equalize, isn't it? So when that happens, the murmur dies out. So you hear it in the left third intercostal space, which is the second aortic area. The duration and intensity of this murmur are proportional to severity of aortic regurgitation. In aortic stenosis, when the stenosis is very severe, the murmur might actually die down because the cardiac output is so poor. The severity of aortic stenosis can be told by the systolic blood pressure, the peak systolic blood pressure. It can be told by the pulsus parvus et tardus. It can be told by the S2. If it's paradoxically split, that means the uh, aortic stenosis is severe, because that's what is causing the left ventricle to empty very slowly and the A2 to come very late. Here, AR severity, you listen to the duration and intensity of the murmur, the diastolic murmur of AR. So with severe AR, one criteria for diagnosis of severe AR is a holodiastolic murmur. So while we are saying that this is an early diastolic murmur, typically With severe AR, it becomes holodiastolic. You can hear it in the entire phase of diastole. If this murmur is more prominent on the left side of the sternum, you're dealing with valve disease. If it's more prominent on the right side than the left side, you're dealing with disease that's predominantly affecting the aortic root, right? And you might hear an Austin Flint murmur. That's because the regurgitant jet from the aorta hits the anterior mitral leaflet. So it's a functional murmur. It does not imply that the patient also has mitral stenosis. Okay. How do you treat severe AR? So if there is acute AR, and that can happen as we discussed with infective endocarditis, it can happen with retrograde aortic dissection, and they will come with cardiogenic shock, which is why knowing this is very important, that aortic balloon counterpulsation, IABP, intra-aortic balloon pulsation, is contraindicated. If you do that, it will cause more blood to regurgitate into the left ventricle. You avoid beta blocker therapy because that would further reduce the cardiac output. Okay. You stabilize, you can use intravenous diuretics, you can use vasodilators like sodium nitroprusside, but basically you urgently need to do a valve replacement surgery, right? And with chronic AR, what do you do? If they are asymptomatic, you just treat their hypertension because that helps. If you reduce the afterload on the left ventricle function will not deteriorate as fast, isn't it? If patients are asymptomatic, but their ejection fraction has started to fall, as just a small difference, if it's just less than 55%, that's indication for doing an aortic valve replacement procedure. If you delay this here, the outcomes are poorer. Okay. When patients are symptomatic, then of course you need to do replacement surgery. And Marfan syndrome with aortic root dilatation, these patients do very well when they're given either of losartan or beta blocker. This retards or slows down the rate at which the aortic annulus or the aortic root enlarges. Okay, I'll see you up next on the other end with pericardial and myocardial disease.